Hello, everyone. Thanks for joining us on this noon COVID-19 webinar. We have a panel of experts here. We really appreciate your time. We think this will be very educational. We're first going to introduce ourselves. My name is Rob Hromis. I'm Dean of the Long School of Medicine and an oncologist by training. And we've assembled 5 experts here to help you better understand COVID-19 and what it means to you where you work and live. And I'm going to ask each to introduce themselves briefly in turn, starting with Dr. Jason Bowling. Jason?
Hi, my name is Jason Bowling. I'm a clinical associate professor in infectious diseases. My areas of expertise are infection prevention and hospital epidemiology, and I'm a hospital epidemiologist.
Fantastic. Tom Patterson, you're up next.
Thanks, Rob. So I'm Tom Patterson. I'm a professor of medicine here at Long and the chief of infectious disease, and I've been one of the lead COVID-19 infectious disease people at University Hospital and principal investigator for the ACT trial, the Adaptive Clinical COVID Treatment Trial.
Thanks. Jan Patterson, you're up next.
Hi, I'm a professor of medicine, infectious diseases, and pathology. Am a healthcare epidemiologist and quality improver, have worked with our health departments for many years, and have also been an advisor to the CDC.
Thank you, Jan. Monica Gutierrez, you're up next.
Hi, I'm Dr. Monica Verduzco Gutierrez. I'm a professor and chair in the Department of Rehab Medicine, usually taking care of patients with stroke and brain injury and spasticity, but I've been doing a lot of work in post-COVID, where I put together a post-COVID recovery clinic. Happy to be here.
Thank you. Ruth, are you on?
Can you hear me?
Yes.
Excellent. I'm Dr. Ruth Berggren, infectious disease specialist, a colleague of these wonderful people on this seminar today, and I direct the Center for Medical Humanities and Ethics. During COVID, I've also been an advisor to Bexar County.
Thank you, Ruth. What we'll do for the first half of this panel of experts is I will ask each of them 2 questions in the area of their expertise, 1 question at a time, going through all the panelists. And then we've assembled 8 questions from the audience in which we will ask each of them those questions for the second half. If you will use your chat function, audience, to ask other questions, we will try to get to those as well. With that, we're actually going to start with Ruth in alphabetical order. And Ruth has been instrumental in leading the effort against COVID-19 in Bexar County nursing homes. So the first question to you, Ruth, is, what can you personally do if an elderly loved one gets COVID-19?
So the answer to that question should really be considered from the perspective of whether your elderly person is living with you, which is soon going to be the case for me because my mother is coming to live with us, whether your elderly person is living independently or within a nursing home. Back in August, our nursing homes began to open up in very limited ways, and there were 5 different ways you could see your loved one. And this is all being organized through Center for Medicare and Medicaid Services. And so the options depend on the facility. Each facility would have had to apply for permission, and the options range from seeing someone through the window, which of course is the most restrictive, to drive-bys, to outdoor visits, to limited in-person visits. And these the approval for those kinds of options depends on whether they have had any cases or not, and whether all their safety measures are in place. So that would be what's happening if your loved one is in a nursing home. Please remember that wellness, especially for all of us, but especially for our elderly, includes not getting disconnected. So we can actually be socially connected while being physically distanced. And so something loving that you can do is to remind your other family members to check in frequently with that person. Make sure they have a device that they can use for Skype or FaceTime or Zoom, and help them learn how to use that. If the loved one is in your home, of course, you need to take all the precautions that I hope everybody's been hearing about over and over, not only from us, but also from the CDC and other sources. Masking is important, keeping that person separate and using their own bathroom is important, keeping them well hydrated, and then monitoring them for the signs that they may need to go to the hospital. We sometimes have people using pulse oximeters at home They are now available again in our pharmacies. And so if you learn how to use the pulse oximeter, that can be something that can indicate to you when it's time to actually get help and get to the emergency room. I'll stop there.
Thanks, Ruth. Next question is for Jason. Jason Bowling, what are ways to prevent COVID-19 besides masking, hand washing, and social distancing? For example, does the flu vaccine help?
Sure. So those are the main three for to prevent infection, but obviously making sure that you're doing regular health maintenance. So the flu vaccine is important to prevent yourself from getting the flu. It won't protect you from COVID-19, but it's important that you protect yourself from influenza since we have a vaccine for that. There is evidence demonstrating that people can get co-infections with both SARS-CoV-2, the virus that causes COVID-19, and influenza. So getting the influenza vaccine is important because it's available. You can protect yourself against influenza. There's been some interest in BCG vaccine to see whether or not BCG vaccine can provide some protection. It's been shown to have some immune benefits against non-targeted RNA viruses like influenza. And there was some epi-evidence early on in the pandemic that it might have some benefit there, although more recent data shows that getting it at birth probably doesn't provide benefit. It tends to wane after 15 to 20 years. However, there's some randomized controlled trials going now for more recent BCG vaccines. And so we're waiting for that to see if that might provide some benefit.
Okay, thank you. Dr. Gutierrez, what are some of the long-term effects that you are seeing frequently after COVID-19 recovery? Oh, on mute.
Quote of 2020. Unmute, you're muted. All right. So I think it's two different ways. It just depends if the patient had a very severe course and they were in the hospital and we're in the ICU, then with those patients, we're seeing the typical PICS, which is the post-intensive care syndrome. So with that, we're seeing a lot of weakness and debility. Patients aren't getting mobilized. Maybe we're prone for a long period of time. Proning, we've seen some neuropathies related to that and plexopathies. So definitely the physical aspects affected. Also, we know with PICS that there can be cognitive deficits related to that, as well as we know that COVID-19 can cause some brain ischemia. There's ACE2 receptors in the brain. And so we know that cognitive effects have been very common in those severe hospitalized patients. And then the psychosocial component with anxiety, depression, PTSD. So that's the realm of people who are hospitalized. And then we have patients who had more mild or moderate disease who didn't have to be hospitalized, but were at home and were suffering with the disease at home. And then there's a subset of those patients who maybe didn't get 100% better, and they're the long haulers or having the post-COVID syndrome. And the most common things we're seeing with that is, number one is fatigue, shortness of breath, inability to do exercise, muscle aches, pains, numbness, headache, along with a slew of other symptoms. Still, inability for taste or smell to come back, weakness, difficulty concentrating, brain fog, anomia. So that's the realm of things. Plus, again, people being anxious, depressed, PTSD from everything that occurred to them.
Thanks, Monica. Dr. Jan Patterson, what are the best vaccine candidates and what is their timeline?
Well, it's a real exciting time to talk about that. There's about 10 vaccines that have reached the final stages of testing and are approaching submission to the FDA for an emergency use authorization, or EUA, which means a product may be effective and that benefits are thought to outweigh risks. This weekend, Pfizer announced that their vaccine that they've developed in partnership with BioNTech, a German company, it's a messenger RNA vaccine. They plan to submit an application to the FDA for EUA approval the third week in November. They believe by that time they will have enough COVID cases in the cohort comparing the vaccinated to unvaccinated to placebo to determine efficacy. Now, the FDA guidance is that vaccines should protect, that is, prevent or decrease severity in at least 50% of those who receive the vaccine. And you must also have at least 2 months of safety data for more than half of those vaccinated. So a November submission will mean that the Pfizer vaccine could receive an EUA in December or even late November. Now, for Operation Warp Speed, the phase 3 studies right now, there's the Moderna vaccine, another messenger RNA vaccine. There's the Oxford AstraZeneca vaccine, which is a non-replicating adenovirus vector. It's currently on hold after an adverse event, a serious adverse event in the UK. It's on hold in the US. The Johnson & Johnson vaccine, which is also a non-replicating adenovirus vector, was just put on hold last week in the US due to an AE, adverse event. Novavax has a very promising recombinant protein subunit with adjuvant vaccine, so a more traditional vaccine approach. It's getting ready to open trials in the US, and UT Health has been approved as a study site for that vaccine, and we're scheduled to begin the trial in November. And then Sanofi, GSK, has a recombinant protein subunit. So there may be some vaccine available before the end of the year from Pfizer. It will be very limited supply. Initial administration will be likely in closed settings, places of work, and congregate settings.
All right, thanks, Jen. The last question for our first go around of our expert panel, Dr. Tom Patterson, what are the most effective current therapies?
Yeah, thanks, Rob. So this has really been also a very exciting time for drug development in COVID. If you think about it, we didn't even know about the disease, obviously, till the end of 2019, COVID-19. And now we already have several therapies that seem to have efficacy against this disease. One of the most promising, and certainly not the cure-all, has been remdesivir. It's the only antiviral that's actually approved for treating COVID-19 and acts in a direct way to stop replication of the virus. Those trials were done at UT Health in partnership with the university as one of the study sites in these ACT trials, and compared remdesivir to placebo. This randomized placebo compared trial showed recovery improved from 15 down to 10 days. Doesn't sound like a huge difference, but it really can make a major difference in some patients, perhaps those earlier in the course of their illness. So that's important to keep in mind. It trended toward better survival in this randomized trial. You may have heard this weekend results from the Solidarity trial that didn't show those results, but that trial may have treated people later. We still don't know that. It's not really been a peer-reviewed manuscript yet, but we wonder if those patients were treated in the later inflammatory stage. We do know that inflammatory stage is also effectively treated with dexamethasone. So in patients who need oxygen, even with more severe disease, like with mechanical ventilation, mortality in the recovery trial from the UK showed pretty significant benefit. So those are two of the major therapies we have. We've also used plasma. Plasma also has an EUA. That hadn't really been subjected to comparative trials yet, and those are ongoing even as we speak.
All right, the combination of any of those better than any one alone?
Yeah, so that's a really good point as well. You know, could drugs act in concert? There are other antivirals. One is called favipiravir. It acts in a different way from the remdesivir. Could those be in combination? And those studies really need to be done. But studies we are doing are looking at combinations of remdesivir, the antiviral, compared with anti-inflammatories. And those two together may give us a double hit against the disease, if you will, one against the virus and the other one against the inflammation that can be so profound and devastating in many of these patients.
You're referring to remdesivir and dexamethasone. Let's go back to Dr. Ruth Berggren. Ruth, you helped lead the county efforts in managing COVID-19 on a population basis. Retrospectively and prospectively, what interventions do you think will really make a difference to prevent the spread of COVID-19 on a population basis?
Well, I'm going to focus in on the ones that I've participated in, which are nursing homes and the carceral population, i.e. the Bexar County Jail and the juvenile detention centers. These are really important areas to focus on because they are kind of like the canary in the coal mine, but they are also dynamic places. Even when we think of a jail as being locked down or nursing homes, which have sometimes been on a lockdown, people have to go into those places and come out to the community. So we have to focus there, one, because there are vulnerable people there, medically vulnerable people, and two, because they're close together. It's easy for COVID to be transmitted. It's harder to control, and it can spread from these centers out into the population at large. So we have to pay close attention. Now, early on, when we were hearing about a lot of deaths in our nursing homes, I reached out to Metro Health and said, how can we help? And they were extremely overstretched at that time, and they really didn't have the bandwidth to get around and make visits to all the nursing homes to see if they had adequate protective equipment, and even if they had the most up-to-date prevention guidelines in place. And so we were able to, with the advice and the supervision and the designation of Metro Health, to go around and visit at-risk places, make sure people were using masks properly, and putting into place all of the guidelines. And with that, you know, if you look at some of our numbers in Bexar County compared to the rest of the country, of 1,209 deaths in Bexar County, 193 or 16% were in our nursing homes, and that compares to more like a quarter of all Texas deaths are in nursing homes, and nearly a third, 27.7% of deaths due to COVID in the United States have been attributed to these long-term care facilities. And so the fact that we have a lower percentage may reflect that we have a different demographic and a younger patient population here in San Antonio and Bexar County, but it also, I think, does speak very well for the proactive efforts that were set in motion at the very beginning. And now, if I could move on to the jail. Bexar County Jail has currently about 3,900 inmates. At the beginning of all of this, there was an effort nationwide for decarceration, and Bexar County did participate in that, and we were able to get the jail population down to roughly around 2,000. Since that time, however, it's been very difficult to transfer people into the prison system, and the prisons have had their own set of challenges, and for all kinds of reasons have been very reluctant and careful about bringing jail inmates into the prison system. Early on at Bexar County, even before we had widespread testing available in the community, we were able to implement testing of asymptomatic people, and then we separated positive from negatives in the jail and put forward a protocol so that everybody who's coming in gets tested whether they're symptomatic or not. And we have special isolation protocols, and we've worked with the jail to help them with their distancing and hygiene measures, help them to work towards getting better availability of protective equipment for not only the inmates, but the detention officers. We've had only one death within the jail due to COVID. And sadly, there has been a death in one of our detention officers who did have COVID. And so it takes its toll, but I believe that we've been ahead of the curve, and I continue to participate in that weekly jail phone call, as does our colleague, Dr. Brian Alsop from University Health System.
Thank you, Ruth. Next, Dr. Jason Bowling. Jason, the majority of folks that get COVID-19 don't get admitted, don't even go to the emergency room. If you get COVID-19, what can you do to take care of yourself at home?
Yeah, that's a great question. And you're right. Fortunately, most people don't have to be admitted to the hospital. If you're at home, the key thing is to have a plan. So one would be ideally think of who you would call if you get sick. Obviously, if you have severe symptoms, you're going to call 911. Purchasing a pulse oximeter, if you can, is helpful. Those are now available again, as Dr. Bergen mentioned, at pharmacies. Walmart has a model. It's available for $20. I don't get any disclosure. I don't have any interest in Walmart. But if you check your oxygen saturation, you should, if you have a pulse oximeter, check it twice a day at home. Don't wait for symptoms, because we have seen people with hypoxia, low oxygen levels with no symptoms. If your oxygen level is less than 90%, you need oxygen supplementation and you need to be seen. And then the symptoms that you should be monitoring for, if you're having any shortness of breath or difficulty breathing, particularly if you're having trouble breathing, just doing your normal activities, if you have any chest pain, if you have any problems where you think that you're feeling confused or having trouble staying awake, those are all warning signs that you need to be seen. Obviously, if you have any of those, particularly severe symptoms, you should call 911. But short of that, checking in with somebody, particularly if you live alone, having a contact you can call at least once a day, so you can let somebody know how you're doing proactively, is probably also a good way, because we have seen people get sick. Initially, they didn't need to be in the hospital, but they've been at home and their symptoms have gotten worse. And so for the week after your diagnosis, you should probably be pretty proactive as far as monitoring your symptoms.
Thanks, Jason. Next, Dr. Monica Gutierrez. You mentioned a number of long-term problems, both with folks that were hospitalized in ICU, but also those folks that just have the long-haul symptoms from having COVID-19 at home. What are some of the things that they can do alone at home to get better, but some of the things that a rehab expert like yourself would do in the clinic?
Mm-hmm. Great. So I always like to say my specialty came out of the polio epidemic. So it was another epidemic. And I said, okay, this is our time to step up and take care of patients where we can see them as soon as the ICU to outpatient. So for someone who is suffering at home and has these long-term symptoms, we use kind of our general rehabilitation principles to help patients with the different symptoms that they may have. Now, if they're feeling short of breath and they can't exercise, once they're cleared from a medical perspective, meaning some patients will need pulmonary function tests, and if they're cleared from that perspective, then good. If they're having cardiac symptoms, we have to clear them for, and there are guidelines out now where you're looking at troponins, you're looking at EKG, and you're looking at echo, and some patients maybe even need more workup or a cardiac MRI. And once those are cleared and fine, then we know that we can start either a pulmonary or a cardiac rehabilitation program or a generalized rehabilitation program. Exercise is good to get back to activity after a certain time. You don't want to start it right away. It's almost like concussion, graduated, return to exercise slowly, not go out and try to do 10 miles on the first day, but you start just by picking up your mail, and then the next day you walk half the block, and then, the next week you do the whole block. So definitely what we know about COVID, it turns the body into an inflammatory state. There's a lot of, the cytokine storm, there's interleukin surge, and this is what's making people feel bad. And also the vessels are leaky, it's crossing into the blood-brain barrier, and people are also having some of the neurologic symptoms as well. So again, it depends on their symptomatology. If it's just physical, we can give them rehab. If it has to do with they can't find words and it's more mental, then we're using things like speech therapy, sometimes even medications to treat patients who are having memory issues. If it's just overall, I'm trying to encourage getting patients into a less inflammatory state. So that means, are you doing things that are right for your body? Are you getting the sleep that you need? Are you getting the social contact that Dr. Megren talked about earlier? Are you getting exercise? Are you eating the right foods and putting the right foods in your body? And then also recommending things that are doing meditation, which also can help with that type of state. And so there's also things to do if people lose their sense of smell and it's not come back. And so we work on, smell training. We work on nasal steroids, and those kinds of things can be done for some of those maybe minor symptoms. And so really it's, getting people to try to change their lifestyle for the better, but also work on the different symptoms that they may be having.
Thank you, Dr. Gutierrez. Dr. Jan Patterson, you're up next. Two-part question. What are the chances of this becoming endemic in the population? And then what are the chances of reinfection after an initial COVID-19 infection?
Well, we're still learning a lot about immunity to COVID. We know that antibodies vary significantly among those with illness. For instance, some do not qualify for plasma donation after infection because they have a low titer of antibodies. In some studies, higher titers correlate in those who've had severe disease, but higher antibodies do not necessarily correlate with better outcome. We are also learning that, and looking at the documentation of standard antibodies, they decrease after 3 months. A recent study out of University of Arizona, though, shows that those antibodies are produced by short-lived plasma cells, but they've also documented antibodies produced by longer-lived plasma cells, indicating immunity for at least 6 to 7 months. And then, of course, other studies have documented T-cell responses that are not measured by the antibody tests and also suggest longer protection. We do know from the previous seasonal human coronavirus studies that those viruses tend to generate immunity, natural immunity of 1 to 2 years. And we know from previous studies of SARS-1, the 2003 version of SARS, that some maintain immunity for years. As far as reinfection, so far there have been few conclusively documented cases out of the more than 40 million cases now worldwide. So our current thinking is that this is relatively rare. However, we don't yet know whether this will continue to be a rare or a common occurrence. And we also don't know how previous infection will affect reinfection, although a couple of the reinfection cases appear to be more severe than the initial infection. In these documented cases of reinfection, they appear to occur after about 3 months. And of course, our testing issues are difficult simply due to the long shedding of RNA fragments after initial infection. So there's still a lot we don't know about immunity, but we think reinfection, at least at this point, is relatively rare.
All right, thank you, Jan. Dr. Tom Patterson, what are the most promising new therapies that are on the horizon?
Yeah, thanks. So there are therapies that are coming along. One of the issues that's important to recognize for the pandemic and the urgency of needing new drugs is the repurposing of compounds we already have. That's done initially by screening to see if you have activity against the virus, but that doesn't always translate into clinical efficacy. And a couple of good examples of that might be hydroxychloroquine or Plaquenil, which got a lot of press early on for either preventing or treating SARS-CoV-2. And in a number of studies now, we've shown that Plaquenil, hydroxychloroquine, really hadn't been effective for either treatment or prevention. The Solidarity trial just released also showed that, the Recovery trial did, but a number of randomized trials as well. Similarly, drugs like azithromycin that we hope to be kind of an immune booster haven't shown a good activity in clinical practice, or even the HIV drug, lopinavir ritonavir, an HIV drug that has in vitro activity against the virus, but hasn't had good clinical efficacy overall. So I think we'll continue to see other drugs come along. One I mentioned earlier was that favipiravir, a drug that was initially used in influenza and is approved for that.
How do you spell that, Tom?
Favipiravir, F-A-V-I-P-I-R-A-V-I-R.
Right.
There you go.
Favipiravir.
But there are other drugs. One is a drug being developed by a company called Ridgeback in cooperation with Merck. It's a drug that is a specific antiviral developed at Emory. Its initial designation was EIDD. You may see that in the literature. But that drug has very good in vitro activity and is entering clinical trials as well. It's an oral drug, and so that would really be an advantage if we were able to give oral drug, just like we are with influenza. You know, with influenza, we want to treat really early, right? And having the patients come into hospital to get remdesivir is a real disadvantage for that. You know, we don't really want patients to come in hospital. Patients are loath to come in the hospital. So they'll put that off and, you know, not be treated early. Whereas if we had an oral drug, that would really be encouraging. So there are a lot of companies looking and institutions, investigators looking at oral compounds that have direct activity. But I'll also add that there's a lot of interest in the best way to look at combating the inflammation that our other panelists have spoken about and the complications that occur from that. And so we're looking now at a number of drugs. One is this drug called baricitinib, and a very high top level results from the ACT-2 trial that showed that baricitinib, which is a drug for rheumatoid arthritis, that drug in concert with the remdesivir in patients who required especially more intensive oxygen therapy, so they're already probably entering the inflammatory stage, those patients actually seem to recover substantially better than with just the remdesivir alone. So I think there are a lot of promising new agents out there, and stay tuned for the drug development that'll continue over these next few months.
Thank you, Tom. Now we're going to turn to audience questions. We're about halfway through our presentation, and some of these questions have already been emailed and some are being texted as we speak. We'll get through as many as we can. If we cannot get to your question, we will reply back in an email if you will put your email back onto the text. The first question is for Jason Bowling. Do COVID-19 patients who are currently on statins or ACE inhibitors have more serious problems? Do those medications suppress the immune system, or are those patient outcomes more related to the comorbidities they have to be on those medications? Jason?
Sure. So yeah, that's a great question. And really the question about statins has come from some time now, how much statins might either improve outcomes or change outcomes, but it's always been a bit tricky because it's confounded by the fact that they're usually on for an underlying medical conditions. It really appears that it's more related to the underlying medical conditions. A lot of the medical conditions that cause people to have high risk for complications for influenza overlap with what we're seeing with COVID-19, particularly things like diabetes, really medical problems, chronic medical illnesses that cover your organ systems, lung disease for obvious reasons, right? This is a respiratory disease, so people with underlying lung conditions are at higher risk for complications. Heart disease, obesity is, particularly a BMI 40 or higher is a real risk factor for having respiratory failure. And a lot of the same things that we see for influenza. We know this also because when we see these patients that come into the hospital with severe illness that have never been diagnosed before and aren't on these medicines, they tend to have these significant outcomes. So we kind of, by looking at it that way, you can tell that it's probably more related to the underlying medical condition than the medication itself.
All right, thank you. The next question is for Dr. Jan Patterson. Jan, was the strain of COVID-19 in New York different and more serious compared to the strain in Los Angeles? And talk to us a little bit about the evolution of strains. Are they getting worse, more serious? Are they getting better? And what risk of reinfection do the alternate strains cause?
Okay, well, the strain that New York and the East Coast appeared to have came from Europe. And of course, that European strain originally came from Wuhan, but there was a mutation that occurred in the strain around February in Europe called the D614G mutation, and that strain is called the G clade or G614. You may hear it referred to. And that strain has become the predominant strain around the world since mid-March. Whereas the very early strains on the West Coast, Washington, California, came directly from Asia and were more like the original Wuhan strain. Now, since that time, the G clade has taken over in the West Coast areas as well. But one reason that New York may have been more severely affected is that they very early on had this strain. Now, there's not really evidence that it causes more serious infection or more severe infection, but there is some evidence that it's more transmissible than the original Wuhan strain. So, when New York first got the strain, they may have had more widespread transmission because of the fact that it's more transmissible. Whereas California, in the West Coast, initially had the Wuhan strain and had a little more time to get prepared and react before they had the predominant G614 strain. But in any case, that G clade has become the dominant strain around the world since mid-March. It's thought that there's 3 major clades of the virus, with the G clade being the most predominant now. And some believe that if you were originally affected with the original Wuhan strain, you may be more susceptible to this more predominant G clade strain now. So that may have some implications in reinfection.
All right, thanks, Jan. Next up, Dr. Monica Gutierrez. Do patients with hypoxia become better by proning them, make them lie on their belly and proning? Can you do this at home, or is this only something that should be done in the ICU with someone who's very hypoxic and about to go on the ventilator or already on the ventilator?
So I think it's something that people are able to do at home for, to help with any symptoms they might have or to prevent any hypoxia. But the reason that proning is done, it improves arterial oxygenation. When someone's proned, it helps it get better oxygenation to the dorsal part of the lungs. And it may be something that has been seen to help prevent maybe patients from getting intubated. And knowing that, being intubated is going to be, you'll be intubated for a while, and also just the procedure of being intubated is more likely to put healthcare workers at risk of being exposed to the disease. So for that, we know that it's good for, BQ mismatch, et cetera. And so it's something that occasionally people are doing at home just on their own, that they're, trying to prevent getting ill. They can go ahead and lie prone. Again, depends on the situation and the size of the patient. We know that sometimes there can be some neuromuscular complications, especially when someone's prone for a long time. But that is kind of what we know about it right now.
So you can do it at home if that it might help. The next question is for Dr. Ruth Berggren. Ruth, have there been much inside hospital, non-social transmissions of the virus, say from patient to patient, or patient to physician, or patient to their visitors, or vice versa, in our Bexar County? And if not, shouldn't we be highlighting the fact that our hospitals are relatively safer than most people think they are?
Yeah, I think maybe that question was best for Dr. Bowling, who is our infection control specialist for a university. We have not been seeing transmission inside the hospital, and that speaks very highly of everybody understanding the guidelines and also of our hospital system for getting us the PPE that we need. And I'll let Dr. Bowling add to that.
Okay.
So I completely agree with what Dr. Berggren has said, and we were very fortunate now to have several months of this pandemic under our belt, and we can see that the PPE has been effective. It has been keeping our healthcare providers safe. We've recognized that we have to have visitation policies to make sure that our visitors enter, they're doing it safely, so we prevent risk there. We have seen issues now that we've relaxed our visitor policy a little bit, reminding people we still have to wear the masks. We still have people screening on entry to the hospital, because we know that's also important too. People forget that if they're symptomatic, they shouldn't come into the hospital setting, and so kind of redirecting that has also been helpful. But I agree, it's important to highlight that the PPE is effective. The masks are effective. This is not really a subject of debate at this point. It's just a matter of people wearing them consistently.
So those folks with other illnesses should not avoid healthcare simply for fear of COVID-19. In hospital or in clinic, communication of the virus is extremely rare. So what are the chances of someone contacting COVID-19 from touching a surface? How long does it last on surfaces compared to respiratory? And I'll go back to Jason for that.
Yeah, that's a good question. And it really depends partly on the surface and in the environment. So that if you're in a cool environment, it can vary. Hard, non-porous surfaces, the virus can last longer. And so it's important that high-touch surfaces like bed rails, doorknobs, and other things are frequently disinfected. The virus doesn't do as well on porous surfaces or fabrics. It doesn't seem to last well there, which is good news in that clothes and things like that don't seem to be very good vehicles for transmission of the virus. It's been shown to last for anywhere from a couple of hours to many hours, to actually some days now. There was an Australian study that came out that showed that the virus could last for a long time on a surface in the right conditions. But more evidence that really high-touch surfaces, particularly non-fabric surfaces, should be frequently disinfected with standard disinfectants will readily kill the virus.
So this question is texted from our audience to Dr. Jan Patterson. How soon before a vaccine is available beyond healthcare workers? So you talked about a vaccine being available perhaps November, December, if it's the Pfizer vaccine and the data shows that it's both safe and effective in over 50% of the population. And that's likely to go to healthcare workers dealing with COVID-19 immediately. But for an elderly patient with, say, diabetes, how soon before they get a vaccine?
So the ACIP and CDC has been developing guidelines on the critical populations for COVID-19 vaccine. And as you said, we expect that the critical infrastructure essential workers will be prioritized first. That would be healthcare workers, frontline, inpatient hospital, long-term care workers, those who provide direct care to high-risk people, EMS, pharmacy, public health, and critical infrastructure like first responders, even education, then people living in congregate settings. And then after that, you know, those at high risk for severe illness or impact from COVID, such as those in long-term care, those over 65, those with high risk medical conditions, certainly diabetes, obesity, we've seen have been very high risk, and also those disproportionately affected because of race or ethnicity. And then finally, those with limited access to vaccination, those in the rural areas are medically underserved, disabilities making it hard to access healthcare, and uninsured or underinsured. So we anticipate that, you know, December, January, there will be a very small amount available as far as, you know, national supply, but that supply will increase substantially, probably around the March, April timeframe, and open to pharmacies, doctor's office, clinics, and public sites. There are, you know, some obstacles to overcome in terms of the vaccine. All but one of the highest priority vaccines right now require 2 doses, 3 to 4 weeks apart. And then there's cold chain storage to think about and handling requirements. For instance, the messenger RNA vaccines are required to be frozen, and at least one of them at ultra low temperatures. So there are some handling requirements to work out in terms of the cold chain for some of the vaccines. So there will be some challenges. You know, providers will have to register to be COVID vaccine providers. There's information about that on the DSHS, the Department of State Health Services website. And each vaccine dose will have to be accounted for, either whether it's dosed, wasted, lost, wherever, and there will be allocation of the vaccine to those who provide vaccines. So it's going to be complicated, but we can anticipate that in the spring, it will become more widely available to the general population.
Okay, thanks, Jan. The next question is for Dr. Tom Patterson. Tom, since being a male is an serious adverse risk factor for intubation and death, would you suggest taking an anti-androgen like some of the prostate cancer drugs?
I thought you were going to say to me that obesity was a major risk factor. And I take that personally, but you you know, we don't know some of those things. I suspect we're going to learn a lot in the coming months. This is going to be with us for a while. It's not going to go away. We've learned a tremendous amount about our approach to these therapies. And so we may learn some of those things, and we may want to do some of those preventive measures. But I would encourage the viewers and listeners to really go with the science. You know, you really got to be careful not to try things that you just see on the internet, because you can see a lot of stuff on the internet. But there's a lot of good science that's ongoing. And so try to be patient with trials and follow the evidence. And, you know, I think otherwise we can do serious harm to our patients and ourselves. So I'd really be careful about trying therapies without a reasoned response.
My understanding is that the benefit is to women as opposed to the adverse risk factor to men. They have the extra X chromosome, which has 70 immune response related genes on it. So having twice as much expression of some of those genes confers a benefit as opposed to being male confers a risk. The next question is for Dr. Monica Gutierrez. Monica, if someone is beginning rehab after COVID-19, would you suggest PFTs and a stress test before beginning rehab, or what testing before beginning rehab?
So it kind of depends on the symptomatology. Again, if they have major lung, if they had more severe disease and had more impaired lung function, then, and we knew that they have risk for interstitial lung disease afterwards, then it may be something that can be tested. For cardiac, yes, I definitely recommend that there's testing. But usually if someone was hospitalized, they will have had an EKG for sure. They would have had an echo, and they would have had troponins and such. And then we know from there, they do have myocarditis. Maybe we need to cool it on what we do. They don't have it. Okay, let's go and do monitored physical therapy on those patients. If it's someone in an outpatient setting and they want to get to an exercise program and they're having ongoing cardiac type symptoms, usually it's tachycardia and dyspnea on exertion, then I would recommend that they would get that workup before doing again, a monitored physical therapy program.
All right, thank you. The next question is for Dr. Berggren. Ruth, the measures you described in the adult detention center are the same measures and meetings occurring for the juvenile detention center?
Yes, the juvenile detention centers are on board and they're testing everybody, and they've done an excellent job.
So, Dr. Gutierrez, can you identify any risk factors a priori that indicate whether someone will become a long hauler or not?
I don't have the data to say who's going to become a long hauler or not. I will tell you in my own experience in the clinic that we have, where we've seen already, close to maybe 100 plus patients, is, some of the long hauler symptoms are happening, or maybe it's just women that are going to go more to seek attention for that. It is not the patients who are hospitalized, but it was the patients who were not, who were at home, had maybe moderate disease. And then also another thing I'm seeing is a lot of psychological disease as well. They were at home, they were by themselves, they were worried, they got ill, they were, just maybe people around them got sick and they were worried about the sickness of their family members. So we definitely know that there's kind of a psychological component with a lot of patients. We're screening them, very high numbers of PTSD, anxiety, depression, and then that's going to make some of the symptoms that they're having worse as well. So we're also addressing any kind of psychological symptoms that they may be having. So it's still being looked at.
So there's the risk factors for serious disease, diabetes has risen to the top, but certainly obesity, hypertension, cardiac disease, any pulmonary disease, cancer remain risk factors for adverse outcomes. These are not necessarily risk factors for the long haulers.
No, it's not. That's affecting anyone. I mean, there could be, a healthy marathon runner and they're getting long hauler symptoms. It's just, I don't know. We don't know yet. Is it their immune response? Don't know.
Jason Bowling, is there evidence that cloth or surgical masks have been shown to be protective for the wearer as opposed to protecting someone else from your infection?
So masks have been looked at pretty heavily last several months. And the good news is that the cloth masks are helpful, particularly they need to have 2 layers. And if they have 3 layers, that's even better. And they protect against both ways. So they protect, obviously, the wearer from getting infected by filtering the air they're breathing in. But they also do decrease the amount of secretions coming out. And so it's large droplet is the primary method of transmission of COVID infection. And the mask prevent people from coughing these large droplets out. So they are protective both ways. The surgical barrier masks provide a little bit better protection than the cloth masks, but both are effective. So people should use what they have. The key is to wear it regularly. And that's the real issue, where there's a lot of mask complacency. Everybody's tired of wearing masks, understandably, but it's really important, particularly in crowded areas where there's going to be multiple people around, that people continue to wear the mask. All
right. Dr. Tom Patterson, what about preventative treatment with vitamin C, D, or zinc, or during the infection itself? Do any alternative therapies help?
Yeah, so they certainly can be helpful, and there have been a number of studies that have looked at them. Especially zinc has been used in other respiratory viruses, and it improves the loss of smell and taste, especially smell. And so we definitely use that in hospital. So that seems to help in some cases. There was one study from, I think, Ireland, maybe they didn't have very much sun, that vitamin D helped. And so we do use vitamin D pretty regularly. The vitamin C story is a little more complex in that really big doses of vitamin C were used. And so we don't as routinely do that. But we'll also add some other agents, like melatonin has been used in some studies. And so those may help regulate sleep, but also may be effective with the virus as well. So there are some adjunctive therapies that are going to be perhaps helpful.
Thank you. Dr. Ruth Berggren, at what point in the future do you feel like the the city, the county, the nation will completely open up again?
Boy, it's hard to predict the future, especially when it involves the future. I think I garbled that quote. I think we need to wait for a vaccine. And I think once we have the vaccine, it's going to take a long time for the whole planet to be immunized. And it'll take us time to get herd immunity. And then we'll still be learning about how durable the vaccines are and whether we need revaccination. So this is going to be a good long time before we go back to life as normal. That doesn't mean we can't live meaningful and productive lives. And that's what I think we should have hope about, is that we really can teach our communities how to go forward healthily with the precautions that we're learning. And we need to encourage everybody not to develop fatigue, not to develop pandemic fatigue, but to hang in there and know that we are going to get through this, but it's going to take much longer than any of us initially anticipated.
Well, and
So-
I think that
Go ahead.
I think the chance of this virus becoming endemic, just being with us, is really high. That's what most people think. If you looked at SARS-1, it was really bad while it was here, right? But then it pretty well went away. We don't see it that much anymore. And the same for MERS. We haven't had it become, a major part of our respiratory viral diseases, where swine flu is a little different. So swine flu, we got a vaccine for it, but swine flu, we still have with us, the H1N1, right? So I think this is going to be around a while. And as Dr. Berggren says, we really are going to have to learn to really live with it. And I think we can do that. And with the vaccine, hopefully the rates of disease aren't anything like we're seeing now, even way less than when we were having a surge.
Someone asked, why not hold this type of webinar several months ago? And the answer to that is we have been holding these webinars weekly for the University Hospital, UT, the 1,300 providers at the VA hospital at University of Texas and at University and at the VA hospital. So we've had weekly updates. It hasn't been open to our alumni or to the public though. But Ruth Berggren has led several public webinars on COVID-19. So obviously the audience that this has gone out to, which is mainly our alumni, have not had the opportunity to take advantage of some of our expertise. And we'll take that to heart and we'll hold these regularly. Next question, Dr. Jan Patterson, has interferon beta have any effect on reducing symptoms? Would that explain the lower infection rate in MS patients on interferon?
Well, it could. I'm going to let Dr. Tom Patterson address that because there is an ACT-3 trial going on right now involving interferon beta 1 alpha.
All right,
So
Tom,
he has
take it
more
away.
details on that.
Yeah, so would that work? Is that crazy? I thought you just heard me say this is inflammation. Would we give interferon, right? Well, I think you do. Actually, a number of profiling studies have shown deficiencies in the interferon pathways that interferon beta 1 alpha may help obviate. And we are looking at that very carefully in studies with the interferon combined with the remdesivir. And it's really thought that may help, especially early on. So it may be a way to prevent progression. It may be after you've already progressed, it's not going to help very much. But really early on, it might. And so I think those are sort of really speculative now, but encouraging that may actually occur. That's a good question.
All right, Dr. Ruth Berggren, with respect to long-term care facilities, what COVID testing protocols are currently required for staff members in general?
Yeah, so that is an area where regular asymptomatic testing is being done. And I hesitate to tell you exactly, you can visit the CMS website to see exactly what protocols are in place, and they may be different for different facilities and depending on availability of tests. But it is the case that those folks who go in and out of the nursing homes are having regular, recurring, every week or every 2 week testing of asymptomatics. And that is something that we are not currently doing at the jail, but we would like to begin implementing. And as resources permit, we're going to step that up. I'm personally of the opinion that we're going to move, as testing becomes easier to do and more widely available, and we get better at it, that there's going to be implementation of regular testing of asymptomatic people who are going into the workplace.
All right, yeah, the new saliva test hopefully might help, but it would be great to be able to have widespread testing of asymptomatic but high risk individuals. Dr. Jan Patterson, what problems will occur with anti-vaxxers not getting COVID-19 vaccinations?
Well, so there is a lot of vaccine hesitancy out there these days, just in general. And then I think, unfortunately, people have perceived that the COVID vaccine efforts have become politicized. There was a lot of talk, about having one before Election Day. And so, people have become very concerned that, safety guidelines are not going to be followed. I think we can be encouraged that the FDA did publish what their guidelines will be for an EUA of the vaccine, and it is, what we would expect based on other vaccines if they were going to be considered for EUA. So at least so far, I think that FDA has held with what the guidelines should be for an EUA, and we trust that they will also have the guidelines that they would use for licensing for vaccines when they do become licensed. I think that if people don't get immunized when the vaccine is more generally available, hopefully in the spring, that will affect the herd immunity issue, which is an interesting topic in itself. I mean, classically, we have considered that 60% of the population would need to have immunity to have herd immunity, that is to limit the transmission of the virus to any significant amount. However, recent analyses suggest it may be more like 50%. And also, we think that there may be more immunity in some subpopulations that are likely to spread the virus, like young people. If they have higher immunity, then that may serve to limit spread in the community at large, even though we aren't reaching even 50%. I will comment about this Great Barrington Declaration that's come out recently advocating just herd or natural immunity rather than trying to prevent spread with our mitigating factors like wearing the mask and so forth, and even vaccination. However, to achieve 50% immunity without vaccination would translate just in this country to somewhere between 500,000 to 2 million deaths. So that is really not a strategy that we can expect to be beneficial. So I think the vaccination is the way to get us to herd immunity in the spring.
Thank you very much. Ruth?
So I just wanted to add on to that with respect to people's attitudes about vaccines. We are working with Metro Health. And when I say we, I'm talking about the Education and Enforcement Working Group of the COVID-19 Community Response Coalition. It's a community-based group of people. Metro Health has asked us to assist them with a survey of anybody who would be in the position of giving a vaccine. So vaccine providers, to understand what their actual physical barriers are, such as do they not have -80-degree storage, all the way to what is their personal hesitation or what are the questions that they have. And we hope to be launching that soon. So if people who are on this webinar are listening and you are people who might be out of sight that could be giving vaccines, please be aware that this will help Metro Health if we can get that survey filled out. It will also allow us to understand what providers think the community's hesitancies are, which will then inform efforts to educate both the providers and the community about the process of getting to EUA approval for the vaccines, and hopefully build confidence in our public to overcome some of the vaccine hesitancies that we know are out there. Thank you.
EUA is emergency use authorization, and it's a step short of full FDA approval, but it's likely the step that any COVID-19 treatment or vaccine will undergo first for release to those in most need. We're at the top of the hour. After 1 o'clock, I'd like to thank all of our attendees for listening in. We'll continue to do this regularly. We really appreciate the time and attention of our panelists. They're true experts, national and international experts in this area. And if you have any other questions for them individually, please feel free to connect with them via Stephen Reese in our alumni office, or you can probably find all of our emails on the web. Thank you very much. Have a wonderful afternoon, and we'll all sign off.
Thanks for joining.
Thanks a lot.